Okay, good evening, everyone. Hope you're all keeping well during these tricky times. Hope you and your family are keeping well and safe at home. Thank you so much for joining me this evening on this webinar, which is titled Essentials of Perio Care in General Practice. So I'm Rena, I'm a specialist periodontist based in London, and hopefully I can make the next hour or so interesting for you. You've probably been webinar overload today. I know we're inundated with webinars, so it's sport for choice really. So you're probably feeling quite tired, and perio usually has this effect on people as well. So hopefully I can keep you awake, and hopefully it'll be a good use of your 1 hour. Just to set the scene a little bit as to why it's actually really important to talk about perio and why it's worth you spending your Tuesday evening learning about it for an hour. Perio is really, really important. It might not be the glamorous, webinars that you're watching at the moment on smile design and composite bonding and all those types of things, but it's going to be really important for us to know about perio inside out. Firstly, because it's so common. You're going to see it on a daily basis in practice when we finally get back to practice. And I'm sure wherever you are working, you'll be seeing perio patients on a daily basis. Hence, it's important to learn about it. The second reason why it's so important is it's now classed as a public health problem. So before, and probably when we learned at dental school, perio is kind of seen as a silent condition, doesn't really have much impact on people's life, but it does. There's now really good evidence base to say that perio does impact on the quality of life of an individual. For example, if you've got a loose tooth and it's painful to bite down on, right, that's going to impact on your ability to eat. If you've got bad breath, it's going to impact on your confidence. So perio has a massive, massive impact on people's lives on a daily basis. It's also classed as a public health problem because of the impact on general health. Now, this is a really interesting area, and I think if you're struggling with motivation for perio patients, you must bring this into the conversation. There's now really good evidence to suggest that gum health is related to good general health. So you can say to your patients now, you know what, Mr. Smith, if you've got this gum condition, then it may impact on your risk of getting diabetes. It may impact on your risk of getting cardiovascular disease. In the same respect, if we can treat this condition, it may impact on your ability to improve your diabetes. So there is quite a big impact on general health as well, which is a great motivational tool for patients. In terms of the final reason why it's so important is it is at the top of the list in terms of litigation. So it's absolutely huge. When we look at the stats, it's actually a little bit scary. So the biggest claims, 3/4 of claims, in fact, are perio and implant related. So there's two reasons people can get litigated against. It's failure to diagnose and failure to refer at an appropriate time. So failure to diagnose, what I mean by that is failure to actually tell a patient that they have gum disease and actually refer them at the appropriate time. So we'll go into diagnosis in a little bit more detail, but what I mean by that is actually giving the details of the diagnosis. So not just saying to a patient, that you have gum disease, but actually saying the severity of it. So you may lose teeth, you may lose teeth as a result of it. So diagnosis is important, and then failure to refer at an appropriate time. So not when they're about to lose teeth, but an appropriate time we can actually do something about it. So they're the two common reasons to get litigated against. So we've established that it's worth talking about perio for an hour. So what we're going to do now is I'm going to take you through the patient journey. So we're going to go through a typical patient journey, and we're going to take you through all the kind of key components that come along your way. So let's get started. So the first thing I'm going to go through is etiology. This is a little bit of boring biology, but I'm literally just going to spend one slide on it. So periodontal conditions are inflammatory conditions, and it's all about biofilms nowadays. Biofilms is your new buzzword. Plaque is kind of the old term, and biofilms is what everyone's talking about. And in terms of etiology of perio, it's all about the formation and persistence of biofilms. It's all about the balance. So if the balance isn't corrected, then you get gingivitis. And if that isn't controlled, then you get irreversible damage, which is called periodontitis. So that's essentially the etiology. The key kind of interesting part of this whole etiology is that as well as changing the balance, it's 80% of the tissue damage that's actually caused by the host response. So that's a huge number. When I first learned about this, I thought, God, is that right? 80% of tissue damage is caused by the host response. Surely it's all about the bugs and bacteria. But actually, a huge component of it is host response. And that's why I always say to my patients, perio is quite an unfair condition. Right? Some people don't even brush their teeth and they're fine, and some people are super vigilant with everything and they still get really severe disease. And that's all to do with the host response, all to do with that reaction by the host, essentially determined by genetics. And this whole interaction between the host and microbiome can be modified by local or systemic factors. This is what we're going to focus in onto. So let's take you through your essentially your patient journey. Okay, so your patient comes in the chair, and this is John, and he's your patient in the chair. I mean, probably all cannot wait to get back to work. So let's dream and hope that this is us very soon. And John, he's got some perio. I know he doesn't look like he's got perio, but he has. And I'm going to say to you, what are the kind of questions you're going to ask him as soon as he sits in the chair? So essentially, there's going to be 7 questions you want to bring into your conversation. And I don't know if anyone's having problems with the sound, but if you do, it should all be all okay. Anyway, so there are 7 history-taking questions that you might want to include. Do your gums bleed? Are any of your teeth loose? Can you chew everything you like to? Do you have a bad taste or bad smell? Do you suffer from any gum boils or swellings? And is there anything else you'd like to tell me? Now, just going back to this, the reason why I'm saying to actually ask perio patients questions is because the number of times at the beginning, after I finished my specialist training and I was seeing perio patients, the number of times they'll sit in your chair and not actually say to you they've got a problem is huge. You'll then put the chair back, do your examination, take radiographs, and you'll think, oh my God, like there's perio everywhere. And you say, are you sure, John, you're not getting any looseness of the teeth? Are you sure you're able to eat what you like? Are you sure there's no bleeding or anything, even when you brush your teeth? And they'll say, oh yeah, I guess that tooth is loose. And yeah, I guess there is a little bit of bleeding when I'm brushing, but I guess, isn't that because I'm brushing too hard? And then you end up, what I found, doing the history of presenting complaint at the end of your examination when you have about 2 minutes to try and explain the value of your treatment. So I found that it's actually important to provoke those questions and provoke those answers from those patients and have like a set list of questions that you ask perio patients, whether you know they're a perio patient from their history, from the radiographs, or from, they may start off by saying something related to perio. So I think really to summarize that, if you're updating your templates, the ones that I would include is bleeding on brushing, loose teeth, bad breath, bad taste. I think people are more likely to admit to a bad taste rather than a bad smell because it's, I guess, less embarrassing. So you can say, do you have a bad taste? And then gum swellings. So those 4 I would definitely include in your templates when you're doing your history. And then the next thing you do once your patient is in the chair is essentially your medical history, dental history, social history, all those kind of things. And this is where risk factors come into play, which is absolutely critical for your perio patient. So what are some of the things that you might see on your medical history form? So the first, biggest, most important thing for perio is diabetes. And diabetes, we all know what it is. It's obviously to do with hypoglycemia. It's a global epidemic. It increases susceptibility and severity. And it's a modifiable factor, so although you can't cure it, you can control it. And control is the most important thing in these patients. If you can control it, their risk is actually the same as a normal healthy individual. So it's all about control with diabetes. So your patient comes in and they've ticked on the medical history form, I've got diabetes. What's the next thing you're going to ask them? So hopefully you're thinking to yourself, well, I want to know, do they have type 1 or type 2? And also, more importantly, I want to know their control. So they're some of the bits of information that you want to get out of them. A couple of tips then. So if they're diabetic, obviously the key thing is medical emergencies. You want to make sure you don't book your appointments kind of just before lunch because you have a higher risk of hypoglycemia. But other things, so ask them their glycemic control. When I started doing this, I used to say to patients, oh, what's your diabetes control like? How's your blood sugar? And the patient would always say yes. And I thought, oh my God, my whole patient cohort's amazing. Like they're all really well controlled. And then soon I realized that's kind of what every patient says. So you've got to get the HbA1c level. And that's a long-term 3-monthly measure of how well controlled they are. And they've recently changed the units for that. So instead of being a percentage, it's now millimoles per mole. So anything 4850 and below, you're good. So always ask that, especially for a severe perio. You can call the GP, they'll easily give you that information. If they haven't got very well-controlled perio, then you might want to see them more frequently. You do need to make them aware that if they do not control it very well, it will reduce the benefits of the treatment. It doesn't mean that you won't provide treatment. It just means that it's not going to be as good as you would hope, and they need to also be aware of that. And on that point, it's actually really important in your treatment plan to put number 1, before OHI and all those types of things, discuss the importance of diabetes control. That should actually be a part of your treatment plan. Be a supporter. What I mean by this is this. So I'm sure you know at least one person with diabetes. It's a really difficult condition to control. There's constantly things to think about. You know, have I eaten this? Have I had my medication? Have I been to my eye appointment? Have I been to my foot ulcer appointment? All these things, there's so many things. And then plaque control is just another one of those things. So we really have to support them in their whole regime, not just their plaque control, but say, okay, John, how can we fit in these interdental brushes? I know you've got so much to think about. When can we make this work for you? Can you give me a time in the day where perhaps this would work? So work with them, support them. And then finally, this is quite interesting. So by doing good treatment in perio patients, by doing good non-surgical treatment, you can actually improve this HbA1c level by 0.4%. So you're probably thinking 0.4%, Rena, why are you even making that a point? That sounds like a tiny amount. Is it even relevant? But 0.4%, although it doesn't sound very much, is hugely significant. You can have a look at the stats there. But a better way to actually explain this to your patient is it's equivalent to adding another diabetic drug into your regime. So it's a bit like you can say to them, you know what, if we can get these gums under control, I know your GP's thinking about putting your metformin because you're not very well controlled. Perhaps if we can get the gums under control, you may not even need that medication. That is hugely significant for a patient. Sometimes they don't really care about their mouth, but they definitely care about their general health. So that's a great thing to say to your patient. And this is a Cochrane review. It's a high level of evidence. So it's not something, it's just like a random case-controlled study. So, we're more than in a good place to say that to our patients. So, with perio treatment, you can have huge benefits. And this is one of them, essentially. So that's diabetes. That's probably the most important one from your medical history. So now we're going on to other things. So immunodeficiency. So what I'm thinking about here is necrotizing periodontal diseases. And that's what it's called in the new classification, by the way. So it's necrotizing periodontal diseases. And it's often associated with immunodeficiency, like HIV, like AIDS. It may not look like this. This is your standard textbook photograph. The reason why is because the medications now are so well controlled. So you're not going to see this kind of severe look. It might just be it might be less apparent. So you need to be even more vigilant. We're looking out for that pseudomembrane, punched out papillae, halitosis, all those types of things. But immunodeficiency, of course, is a risk factor. And other things like pregnancy will come under the medical history as well. In pregnancy, you have hormonal changes. And what I say to the patients, obviously this is the biological side, but for patients, I say your gums become more sensitive. And so before, you could get away with not using that floss or the interdental brushes. Your gums wouldn't bleed. But now, if you don't do that, if you're not on top of your home care, the effects are magnified. So you will have issues. So you just have to be home down on that. With the effects on pregnancy, on the gingivae, they'll either be edematous, so you're probing and it's just profusely bleeding, or it'll be proliferative. So your standard classic pregnancy epulis is a proliferative presentation of this. And the EFP, which is the European Federation of Perio, they've got fantastic resources like the BSP. And the EFP have got some brilliant leaflets that you can download. They're for free. They've got, also got infographics, videos that you can play in your waiting rooms. But these PDFs are excellent, and they're ones you can send to your patients. They're ones that you can read, and there's ones that like FAQs you can leave in the waiting room. So it's worth having a look at them, worth downloading them, because often pregnant ladies will be worried about having perio treatment. And it's really important to reassure them, and it's really important to actually do the perio treatment, because really on the grand scheme of things, and I probably wouldn't say this probably to the patient, but it's riskier to leave it than to not treat it. So it's really important to treat these patients. And then finally, in your medical history, you've got the little bit at the bottom saying, are you on any medications? And the medications that are relevant for perio particularly are these. Phenytoin, cyclosporin, and anything with a dipene at the end is going to cause drug-influenced gingival enlargement. That is the new term, by the way, in the new classification for this condition. Drug-influenced gingival enlargement, not hyperplasia, not overgrowth, it's enlargement. Anyway, look out for these patients. Usually the overgrowth begins in the interdental papilla region and then just essentially becomes more and more fibrous. If it looks like this is bad news because it's a bit of a vicious cycle here. You've got this massive overgrowth. You're not going to get an interdental brush through that, right? There's lots of plaque everywhere. You're not going to get an interdental brush in, which is going to make the situation worse. It's going to be even harder to clean that area. So you're not going to be cleaning very well. So the overgrowth is going to get worse. If it gets worse, it's even harder to clean. So you want to prevent it from looking like this. At this stage, this patient needs surgery. So try and catch it early. And that's why I mentioned that the overgrowth begins in the interdental papilla region. So even if they're on any of these medications, pay close attention to the interdental papilla. If you see it even overgrowing a little bit, then that means that something's starting up and you need to hone down on the oral hygiene instructions. So that's medication. So that's your medical history. So we've literally just looked at your medical history form and we found all of that already. So what about family history? What about genetics? So genetics is actually hugely important in perio patients. And in fact, 50% of susceptibility is related to genetic factors, which is huge. As I said before, it's an unfair condition. It's particularly relevant in what we used to call aggressive periodontitis cases. But I would say with this particular point, you need to take the reliability of family history with a pinch of salt. So if your patient comes to you and says, well, my mum, she's like 70 years old and, she lost all her teeth as a teenager, and when she got married, the final ones would take, like, if it's like that, and they just say, I've got weak teeth, I've got weak gums, it's probably not very reliable. But if someone says to you, okay, I'm 32, my sister is attending the hospital for specialist gum treatment, and she's had some surgery, you think, okay, this might be a positive family history. So take it with a little bit of pinch of salt. So moving on to the social history. So again, the diabetes was the biggest one so far. And I would say probably like equally as important is smoking. Smoking is pretty bad news for perio all round. It increases the susceptibility, increases severity. Your treatment's not going to work as well. And even if it does work, it's probably going to reoccur. So it's really, really, really important that we do everything we can to achieve smoking cessation. Obviously, it is dose dependent. The more they smoke, the worse it's going to be. So a couple of things. Smoking cessation is the most important thing. The current kind of advice is AAR. Ask them, are you interested? If they're not, don't go any further. There's no point. Advice, give them some advice. Okay, you really need to, if we can, let's try and get you to stop smoking because it's not great forget your mouth, but it's for your general health, it's not great either. Can I help you with that? There's smoking cessation services, and actually they will triple your chance of stopping. So if you can do that, that would really help you successfully be able to quit. So those kind of quotes are great and they motivate patients as well. Of course, everyone has their individual choice in life, and if they want to continue to smoke, that's absolutely fine. But you have to make sure that you write it in the notes and you have the discussion with them that I'm happy to try and treat your gum disease, but it's very, very unlikely that we'll be able to get a good result for you. So it may mean that after we've tried once or twice, we may just have to maintain what we've achieved, and that you need to be clear with them. So you're probably all thinking, okay, so what about vaping? Is it even relevant? Well, the first thing to say to you is vaping is really popular. There are 3 types of e-cigarettes. When I did my specialist training a couple years ago, I did my dissertation project on e-cigarettes. So this is just a bit of fun facts I want to include for you. So there's 3 generations. Generation 1 is pretty much obsolete. Generation 2 is quite popular. And Generation 3, if you're super cool, you have Generation 3. You can adjust all the settings and, intake and so on. There are 5,000 flavors, right? Ranging from banana to kiwi to chocolate to whatever you fancy, basically. And the reason why I'm saying this is it's so difficult to do good studies because there are so many brands, so many flavors. That's why we actually don't know right now what effect it has on the gums. Unfortunately, my little study that I did for my dissertation just said we need more studies, which is quite a common finding. So unfortunately, we don't really know how it affects the periodontal condition. What we do know, and this is a good paper to read, is that it's meant to be better for your general health. And it's also meant to help smokers quit. If you think about it, right, you've got the patches, the chewing gum, it's not really replicating the behavioral smoking thing, right? So that's why these e-cigarettes are so successful in helping people stop, because it's mimicking what they normally do. So as I said, the effects on the periodontal condition, we don't know. So what I would say generally to patients, firstly, if you are vaping, I'd say if you're using it to stop, that's fine. But really, we want you to stop vaping as well. It's likely to have some effect. So in the same respect with, I said about putting diabetes discussion in your treatment plan and smoking cessation in your treatment plan, vaping cessation should actually be a point in your treatment plan. And that's a kind of the guidance on it at the moment. So that's vaping. And then we move on to a factor which sometimes is missed, but is so important, which is stress. And I'm just worried that I'm going to get to work, and so I've got my peri clinic, and I obviously see peri patients only. I'm worried about my maintenance patients. I'm worried that we've gone through this COVID, very stressful times for everyone, and people are going to relapse. So I'm really worried about that, and I see it all the time. So like, I have patients which we see for maintenance every 3 months, and then the odd patient will come in, normally very good, OH, everything medically, there's no problems, and I do the pocket chart. And it used to be like 3mm pockets, 4mm pockets, hardly any bleeding. And then suddenly the whole mouth has relapsed. And I'll say to them, so has anything changed? Like, has anything happened? And then they'll say to me, you know what, Rena, I'm going through a divorce, I'm moving house. And then you think, that's it. So the stress for those types of patients, for the peri patient, I always say to them, your gums are your weak spot. So if anything changes in your body, it's going to show up in your gums. So stress is actually really important. The mechanisms aren't well understood, but I mean, we can guess immune system and behavioral as well. If you're going through a divorce and moving house, you're not going to be doing your interdental brushes every morning. So it's worth keeping at the back of your mind when you're seeing these patients. And finally, dental history. We're talking about diet here. And this is a really interesting area. I've been reading about it quite a lot actually recently. And there's been some fantastic, Ian Chappell in Birmingham, he's done some fantastic studies on this as well. And there's quite a few components, quite a few micronutrients that have an influence on the periodontal condition, which makes sense because if you think about the structure, collagen and the turnover, the connective tissue, it all needs like vitamin C, vitamin D, magnesium. So all of those things have been shown to affect perio. I would just say right now, the best thing to say to them is, as long as you've got a fairly reasonable intake of good fruit and veg, you're fine. It's really major deficiencies where it has a result, but it does play a role. So we've gone through so many risk factors just by going through the history. And we haven't even picked up our probe yet, but look how much information we've got already that you might think, this patient might be a peri patient, or, we might have to treat this patient a little bit differently. So all of these things are super important, which you can get all from your history. Let's just have a look at a couple of questions before we move on. That are related to this section. So Clive, you already covered regarding vaping being bad for perio. I guess we don't really know, but we would guess it would be. So I would just say vaping cessation. Amir, a good question regarding drug-influenced gingival enlargement. When treated, how do you preserve keratinoids attached to gingivae? Usually, with surgery, we try to take an approach whereby we minimize, we need to cut away the bulk of the tissue. But if there's not enough keratinoid tissue, we'd do our incisions in a different way. So I think if you're not sure, refer. Otherwise, there are various flap. I don't want to go into surgery right now, but there are various flap techniques you can do to preserve the keratinoid tissue as well. Do you ask the GP to change their meds? Very good question. So the question is, when do you contact the GP with the gingival enlargement? The time to contact them, I would say, if it's quite severe, get the ball rolling from the beginning. Commence your treatment, but get the ball rolling, because by the time the patient sees a GP, they have a discussion, the medications change, it has an effect, it's going to, you would have done your first round by then. So essentially get going from the beginning. If it's not very severe, then do one round of treatment. And if it's still an issue, then essentially contact the GP. I was really surprised because initially when I started doing this, I thought GPs just wouldn't be interested in changing the medication, but they are. They really take it on board. Okay, so let's move on. So now we're on to the examination. Chair goes back. The first thing we should all be doing is picking up our BPE probe, which is obviously, everyone knows it's a screening tool, should be done for every single patient, and starting from the age of 7, where we have a simplified BPE. And I'm not going to go through how to do the BPE because everyone knows how to do that. I'm just going to go through with you about the changes that happened with the BPE quite a few years ago now, but just to recap. So there are 6 main changes. The first change was, if you get a code 4, you need to continue to examine the whole sextant. So what I mean by that is, before in the past, right, we would do, say this example here, you probed the 7 and you got a code 4. You'd move on to the next sextant because you've already got code 4. But now, because they've introduced the star as furcation involvement, you need to examine the whole sextant, because here, when you get to the 6, it's now become, there's a furcation involvement, it becomes a 4 star. So that would actually be the better code, or the correct code, rather than just a 4. So that's really important. The second change was, if you get a code 3, then you need to do an extra little step first. So you need to do something called risk factor control. So don't jump in and do a BPE and do a pocket chart and RSD straight away. Take a step back and say, okay, what can the patient do themselves to help? OHI, gross scaling, smoking cessation, diabetes discussion, all of those things. Then close off your course of treatment, get the patient back again. If it's still a BPE of 3, then you do your pocket chart, RSD, all those kind of things. They really emphasize the importance of probing around implants, but not using a BPE, because obviously the tissues around implants are different to that around teeth. So you do need to probe, but better to do a 4 or 6 point pocket chart. Hopefully not too many of our patients look like that. They emphasize the importance of taking appropriate radiographs. When we come onto the new classification in a minute, we'll see how important good quality radiographs are. So always make sure you can see the bone. If you can't see the bone, even if it's like just distal of the 7, you just missed a tiny bit, take a PA. Trust me, it can really change your prognosis when you realize that potentially the bone's like near the apex. So don't take any risks for that. And finally, point 5 was, if you have a pocket chart, especially if you're working alone, this can save you quite a lot of time, is you only need to chart 4 millimeters and above. So only pockets of 4 millimeters above need to be recorded, but bleeding definitely needs to be recorded. Bleeding is very important. It tells you how active the condition is. So always record bleeding on probing. Okay, so that was just the few changes. So when you do your BP, obviously a lot of the time you're going to then need to do a pocket chart. Now, pocket charting is not just probing depth, remember, it's all the other things as well. And especially if you've got like a severe recession defect or grade 2 or 3 mobility or furcation involvement, we do need to chart that as well. I think if your recession is like 1-2 millimeters across the whole arch, you can get away with just writing a general statement by saying generalized recession. You don't need to chart. There's limited time in practice. I'm quite a lenient periodontist. I really understand how much pressure there is in general practice. So just be sensible. If it's really significant, don't forget to chart it. Okay, once you've had a look, you're going to need some special investigations. So as we said, radiographs are a key component of your special investigations. Your parallel periapical radiographs, they are your standard, gold standard, but it doesn't mean the other ones aren't useful. If they've only got initial bone loss, bite wings might be fine. Panoramics are excellent to give you an overview of what's going on. So you pick and choose according to the patient. And when you're doing your radiographic report, don't just focus on bone loss. And I think this is a common thing people make a mistake in terms of perio. I think it's just about bone loss and pattern of bone loss. It's not. Think about other things. And one of the key things is anatomy, right? So if you've got a tooth with really nice, long, tapered roots, the anchorage of that is great. Whereas if you've got a tooth with tiny little conical roots, the anchorage is not so great. So the prognosis, they might have the same amount of bone loss, but the prognosis is completely different. So look at the anatomy, look at local factors, look at overhangs, look at any deficient margins, is there any evidence of calculus, all those types of things. And clinical need will essentially determine frequency. And in terms of reading radiographs, I just wanted to include this as a quick point. I know everyone knows how to read radiographs, but one thing I found quite useful, which when I did my training they went through, is always trying to read radiographs in the same direction. So often what we'll do is we'll just home in on like one thing that's really apparent. But what I now do is I start coronal and then I just read all the radiographs in the same direction. So I'd firstly talk about any evidence of caries, any deficient margins, any overhangs that have worked myself down. Okay, let's have a look at this root canal. What's the quality of the root canal? Is it short? Is it long? Or what about that post? Work your way down. Oh, there's furcation involvement. Evidence of, you always have to say evidence of, by the way, because we never really know. So evidence of furcation involvement, work your way down. What's the anatomy of the root like? Oh, is there any PA area? Is there any radiolucencies there? So you essentially won't miss anything out. Whereas if you just saw that, you might just focus on one thing. So just a little kind of side tip in terms of reading your radiographs. So as well as radiographs, other special investigations will include sensibility testing. And what I mean by that is obviously endofrost or your EPT. And I'd say you do this in a tooth which is symptomatic, or if you've got especially grade 3 furcation involvement or mobility, you'd probably want to have a look at that. So far we've done the examination, we've done history first, then we did the examination, did some special investigations, and now we have to put everything together to get our diagnosis. And this is where obviously the new classification will come into place. So let's just have a look at a couple of questions before we move on to the next section. So we've already gone through the gingival overgrowth. So you said about the overgrowth persisting. So as I said, try and change the medication. If that's not possible, you can refer, and that patient may need surgery. The key thing with these patients is plaque control. If you can control the plaque control, the risk of recurrence and essentially the success of treatment will be much better. Nidhi, you've asked about x-rays during pregnancy, hence you can't diagnose. So, okay, so you can, it depends. If you need a radiograph, like it's going to change what you do, you can take radiographs for pregnant patients. But if you don't need it, you can do initial treatment. And what you do there, just give a provisional diagnosis and then just write further investigations to be completed once the patient's had their baby. But you could do initial treatment for sure. And okay, I think that's it. So moving on to diagnosis. Now, this is the fun bit. So everyone's probably like, basically looking at this, why you need to change the classification. This is like, we already got so much to think about, and now I have to think about this peri classification. Why they made it so complicated? So my aim for the next few minutes is to simplify it. Honestly, it's not too bad, and I think once you get the hang of it, it's much easier. So I just want to simplify this. So this is the table that was in the original classification. Now, the first thing to say is the actual classification, there was a group of, I'll just give you some background, there was a European group of periodontists and an American group of periodontists, and they got together in the States a couple of years ago, and they thought, right, it's time to update the classification. It's been 2 decades, things have changed, we need to move on, which is correct. They released this, and then what happened was, trying to adopt this in UK practice was really tricky. And then so the BSP saved us, a group of us got together and we simplified it. And this is the version we all need to know in the UK. And this is just an important point because sometimes, especially now, we're all at home watching millions of webinars. Just if you are watching a webinar on the classification, just make sure they're talking about the UK one, which they would be if they're a UK speaker. But if you're watching some from Europe and so on, it's slightly different. We've interpreted it and applied it in our own way. So focus on that. But the one that the BSP simplified was this section. So essentially, you still have 2 big sections. You've got periodontal diseases and conditions, and then you've got peri-implant diseases and conditions. So the bit they simplified was the first section. And essentially, and if you want to read the paper, you want some bedtime reading, probably enough learning at the moment. But if you really want to, this was released in the BDJ. I think it's free to access, and we did some case series after that. So that'd be useful for you to read if you want to. If you can't find it, let me know. I'll send you the link. But anyway, there's 3 types of perio diseases and conditions, 3 major categories. The first one's perio health and gingival diseases. The second one is periodontitis, and the third one is other conditions affecting the periodontium. So the one, obviously, that's a new one is periodontal health. So just to say, this is the first time we've actually defined periodontal health. Before this, we didn't actually have a classification for it. And periodontal health is essentially, it's quite easy to remember, 3 millimeters or below in terms of probing depth and less than 10% bleeding on a patient by patient basis. So that one's easy to remember. The one you really need to know inside out is obviously your periodontitis category. So there's only 3 types of periodontitis, which is amazing. I'm sure when you learnt this at dental school, you remember that huge table with like hundreds of types of perio. Maybe not hundreds, but a lot. And now there's only 3 types: necrotizing, periodontitis, just periodontitis by itself, no chronic, no aggressive, and then periodontitis as a manifestation of systemic disease. So periodontitis is now just called periodontitis, and that's important because I think some people are still calling it chronic and aggressive. It's just periodontitis. Now, I'm sure you've seen the flowcharts by the BSP, which are excellent. But even with me, like going through the flowchart, it takes some time to go through it. So I've tried to break it down even further into these 6 steps. So I promise you, if you follow these 6 steps, you'll get the periodontitis classification in like 20 seconds. So I just want to spend a minute or so on each of these 6 steps. Okay, step 1 is type of periodontal disease. So the key sign of perio is bone loss. So the first thing you need to do is look at your radiographs, whether they're existing radiographs, ones from the past, any information you have a look at the radiographs only and see, is there any bone loss? If there is, the next question to ask yourself is the bone loss due to periodontitis? It probably is, but there obviously are other reasons to get bone loss, like even procedures like crown lengthening, other lesions, ortho, impacted eights that have been taken out. There's so many there's so many reasons to get bone loss, but you have to just check, is this bone loss due to perio? If it is, that's your first step done, and you're going to call this a periodontitis patient. You're going to give them the label of periodontitis. That's step 1, super easy. Step 2 is the bone loss, what's the extent of the bone loss, right? Still looking at the radiographs. Is it localized, up to 30%? Is it generalized, more than 30%? Or is it just the molars and incisors? So again, this is so easy. You look at the radiographs, the information you have, and you say, okay, does it look like the bone loss is everywhere, or pretty much everywhere, or is it just a few teeth? So that's, again, easy to do, and then that gives you your second step. Still looking at the radiographs, we then move on to staging and grading. And this is where everyone gets confused, but honestly, it's really, really easy. So what you do is staging is all about severity. How severe is the bone loss? Remember, we are just talking about bone loss here. We're just looking at radiographs, not your pocket chart, not the BP, nothing. So look at your bone levels on your radiographs and pick the worst site. So in this particular patient here that we've been looking at, obviously the upper right 5 is your worst site. And then you ask yourself, okay, how bad is that bone loss? Here we're probably looking at like 90%. It's definitely in the apical third. So you divide the root up into thirds. And if the bone loss is in the coronal third, it's stage 2. Stage 3 is mid-third, and stage 4 is apical third. Stage 1 is like the tiniest amount of bone loss. So divide the root up, and you're just focusing on this worst tooth. It doesn't matter if you have, like, all the other teeth have like 10% bone loss, and you've got this one tooth here that has 90%. If that bone loss is due to perio, you've got to go with the worst case scenario. So go with stage 4 here. Then you go on to grading, and grading is all about susceptibility. So staging was about severity, grading is about susceptibility. So, okay, I've got this 90% bone loss, but how quickly has that bone loss happened? And that will tell you how susceptible your patient is. So if your patient is like a 20-year-old with 90% bone loss, they are really susceptible. If you've got a 90-year-old with 90% bone loss, they're less susceptible than that 20-year-old. So this also gives you an idea of how quickly the disease is going to progress if you don't get it under control. So if you have a patient who says, oh, you know what, doctor, I don't really fancy treatment, and they're a high grade, i.e. highly susceptible, you can say to them, well, you know what, if we don't do this, you are going to lose your teeth. You're very, very susceptible to this condition. So it's a good way to discuss it as well. So with grading, so staging was 1, 2, 3, 4. Grading is A, B, and C. And the best way of doing this, now there is a calculation, but again, there's limited time in practice. We want to make this super quick. So ask yourself, okay, I've got 90% bone loss. Ask yourself, is the bone loss more than my patient's age? If it's more than their age, they are susceptible. So that's grade C. If it's less than half their age, that's grade A. And anything in between is grade B. So that makes it easy, right? Grade C, more than their age. Grade A, less than half their age, and B is anything in between. And that's probably the quickest way to do this. So if you have like a 50-year-old with 70% bone loss, the bone loss is more than their age, so they are susceptible, they're grade C. If you had a patient who's a 50-year-old who has 10% bone loss, the bone loss is less than half their age. So they're not that susceptible, that's grade A. And anything in between is grade B. So I find that's the quickest way of doing it. So that gives you your grade. So we've already done 4 steps. It's not too bad, right? But what haven't we looked at so far? We've only been looking at radiographs, right? So now, remember, we don't treat bone loss. We now want to know what we're actually going to do. But you're probably thinking, well, Rena, why did you waste 4 steps on just staring at the radiographs? What was the need for that? What if the patient has no pockets? Why do I really need to know what the bone loss is like? Well, the point is, once a perio patient is a perio patient, they are a perio patient for life. So you need to know that. You need to give them the label that you are stage whatever, grade whatever of this perio patient, because then it means they'll be on maintenance and they can be maintained. So you need to definitely do those 4 steps. Then you need to know what's happening. So now you look at your pocket chart and now you ask yourself, are they stable, in remission, or unstable? Okay, so stable is the healthy. There's no, what I call open pockets. By the way, it's a really good terminology to use your patients. Open pockets, closed pockets. Open is anything that needs treatment, so 4 with bleeding and above, and closed pockets is anything that doesn't need treatment, so 4 without bleeding after treatment and 3 and below. So stable is no open pockets and less than 10% bleeding. Remission is more than 10% bleeding, but the pockets are still closed. And then unstable is now you've got any open pockets, they become unstable. So again, fairly straightforward. And then that's it, 1 more step and you're done. So the last step is all about risk factors. And now we've gone through all the reason why I spent so long on risk factors is they're so important. And you probably gathered the probably most important ones are diabetes and smoking. The other ones are still important, but the reason why they're not actually included in what we call our diagnostic statement is because smoking and diabetes can be measured and controlled. So they were quite good in terms of including in your actual diagnostic statement. So if you put this all together, this is what we get. And you would just switch around in these 6 steps that I've come up with, just switch around 1 and 2. So the way you'd say it is, generalized periodontitis stage 4, grade C, currently unstable, risk factor smoking. So that should really help in terms of breaking it down. So let's just do, this was the example essentially that I showed you. I just want to go through 2 examples so we've completely got it. So just think about this at home in your head. So you've got 49-year-old, medically fit and well, smoking 10 cigarettes a day, history of specialist periodontal treatment. And this is pocket chart. Okay. These are the radiographs. So step 1, is this a perio patient? We said yes. Step 2, is it generalized or localized? Clearly generalized. Step 3, pick the worst tooth. Upper right 5, we said this. Okay, what stage was it? It's in the apical 3rd, so it's stage 4. Okay, the patient is 40 something, it's more than their age, so it's grade C. Is there, have a look at the pocket chart, there's obviously deep pockets everywhere, so they are unstable. And are there any relevant risk factors? Yes, they're a smoker. So I mean, that literally took me like 10 seconds. So it's so easy if you follow those steps. Let's do 1 more. Okay, so you haven't seen this one. So if you do this with me. So 37-year-old, medically fit and well, never smoker, family history of perio. Okay, this is the pocket chart. Okay, so we did a BP obviously, and then did a full pocket chart because you've got some 4s in there. And then this is the radiographs. So step 1, is this a perio patient? So you should be saying yes. Step 2, is the bone loss generalized or localized? To be honest, here it's a little bit gray, but if you just look at the PAs, you'd probably go for localized here. Step 3, pick the worst tooth. Hopefully you've gone for the lower left 6. Is the bone loss in the coronal, mid, or apical 3rd? Hopefully you've said mid. So remember, stage 2, 3, 4. This one's stage 3. The patient is 30 something. Is the bone loss more than their age? You've said yes. So that's grade C. Okay, then you look at the pocket chart and they're obviously unstable because they've got deep pocket, open pockets everywhere. And then finally, are there any relevant lifestyle risk factors? The answer is no. So the patient, yes, they had a family history, but remember, it's only smoking and diabetes that we take into account. So I hope that helps in terms of breaking it down. If you've got any questions on the new classification, let me know. I produced quite a lot on it. I don't spend the whole webinar on it. Probably fall asleep by the end of it. So if you go onto my Instagram, there's loads of, which is RW Peri, there's lots of whiteboard kind of videos and things like that. And I can send you the papers if you need to. I'll give you my email at the end. So hopefully those 6 steps helps. Okay, so once you've got the diagnosis, we need to give a prognosis, which is just a little step we need to do after, which is quite important from your point of view and from the patient's point of view, because what you don't want to happen is the patient comes back and they lose a tooth and they have no idea that that tooth was vulnerable. So even if you just write a statement like, patient explained, all molars have guarded prognosis and risk of tooth loss, you've covered yourself and the patient's aware. There's various ways of breaking down prognosis. I like to use good, fair, guarded, and then hopeless is basically needs to come out. When you've got all your findings together, quite a kind of critical thing to do is actually translate what you found to your patient. So in terms of when I was doing my perio training, I used to get really excited about getting like a 10mm pocket down to like 3mm, 4mm, and the patients just weren't getting excited. I was like, you know what, I'm doing all this treatment for you, at least kind of get motivated, and they just weren't interested. And then I started thinking, well, maybe if I was a patient, I wouldn't really care about 10mm and 5mm and 4mm. It doesn't really mean anything to me. What does it actually mean? And then I started translating what it actually meant. So I would say to them, look, if we can get this treatment, get this sorted for you, you'll keep your teeth for longer. You won't have to wear those dentures. You won't have that bad breath or bad taste. You won't have blood on your pillow. So translate to, yes, the clinical findings are important for us, but sometimes we don't need to elaborate on them too much for the patient. We need to elaborate on what they care about. And that's where your motivation comes in. Motivation of perio patients is a huge problem. And things like linking it to general health, things like translating the findings to what they care about is going to make a huge difference. Okay, whilst we're on this topic, and I know a few questions have already come up actually on this, which is implants and probing, so I'm glad I've included this, just as a side point, to say that treat implants like you do with a normal perio patient. So you need to probe them. You need to check the oral hygiene, which is normally quite difficult around implants. So you need to spend some time showing them that. You need to routinely gently probe. As I said, you can use any probe you like. The thing about using plastic probes and instruments, it's the argument doesn't really stand. So you can use any probe you like, whatever you have in your drawer, gently probe. As I said, 4 or 6 point pocket chart, check for bleeding, check for suppuration, and get a radiograph as well. Especially if you don't have a baseline one, take one, even if you didn't place the implant. Medico-legally, periimplantitis is a huge time bomb. It's actually already gone off, I think. So even if you don't place the implant, it's still our job to look after it and be able to diagnose if there's an issue. If there is an issue, you don't necessarily have to treat it yourself, but you just need to let the patient know that there's an issue, and you have to have that recorded in your notes as well. Always take that into account. So before we go into treatment planning, again, let's have another couple minutes break and let's go through some questions. Okay, so someone's asked, Smita, you've asked, how can I correctly stage and grade a patient probing depth if I don't get given the correct radiographs? So this is going to be a major problem. I think you have to, the dentists really have to work with the hygienist quite closely to make sure you have the appropriate radiographs. And decide whose responsibility that is. And it's going to be so important to get the accurate diagnosis. I think, Smita, if you were in that position, you'd have to just give a provisional with all the information you have and then put in the notes, GDP, please take radiographs at next visit, and to communicate that. So it's going to be a tricky problem. In terms of OPG, so Raman, would you put OPG in severe perio patients? How frequently? As I said, I think PAs are the best ones because you get the most detail, but OPGs are also good. Just anteriorly, you might need to take some supplemental PAs. How often you need to take them? Well, it depends. If something's changed, the clinical need will determine the frequency. So if that probing that's suddenly got worse or the tooth becomes symptomatic, you might need to retake your PA. But it's not like caries risk, like you have to take them quite frequently. Radiographs don't get old that quickly for perio patients. And let's just take another one or two. Fahimuddin, you've asked if there's bone loss, does it necessarily mean it's active perio? No, the bone loss just means they are periodontitis patient. It doesn't mean that they're active or if they're stable or unstable. It just means they are perio patient. That's all. That's where your step 5 comes into place, is when you know whether they're stable or unstable. You don't need to near-gel. You don't need to take full mouth PAs for the new classification. You only take radiographs where you need to. So if bite wings are sufficient, and that's you then estimate the bone loss. You don't have to take PAs just to get your diagnosis. Of course, if you've got BPs of 4s everywhere, you might need full mouth PAs. So again, clinical case by case. Okay, let's move on. So treatment planning, right. So we've done the diagnosis, now we're going to treatment plan. And I did my specialist training in guys. So I saw the shard slowly being built. And it was really interesting. I was reading an article and they said that they only made about 13 changes when they did this huge project, which is nothing. And the reason why was because they spent 60% of the time planning and only 10% of the time executing. And the same way, planning for perio patients is extremely important. Also is extremely important is taking a step back. So, by the way, with planning, what I mean by that is planning, like, for example, tooth by tooth prognosis, planning if a tooth does need to come out, what are you going to replace it with? All those kind of things. Anyway, also take a step back. I don't know if you know, but last time I checked, a lot of the shard was still empty. And apparently they said in this article that it's because they built it on the wrong side of the river. The other side of the river is booming. And so what I mean, I'm trying to relate everything to perio, but take a step back and look at the patient as a whole. So if you've got a working mum with like 5 children, doing the TP regime first thing in the morning is not going to work out for her while the kids are running around and have to go to school. It might be best that she drops them all off to school or nursery, comes back, and then she has some time, that 15 minutes or so alone time to do her home care regime. But if you didn't know that her circumstances, you would have just said you have to do your home care first thing in the morning, and she probably just wouldn't do it. So get to know your patients. These extra things will make a huge difference to the success of your treatment. So moving now swiftly on to the actual treatment. So the first thing we need to do as part of our treatment plan is provide OHI. Whether you're a dentist or hygienist, because hygienists are the queens of kings of providing OHI, but everyone needs to be involved in this. A couple of tips. We don't have much time in practice. So the time we do have, what can we do to make it effective? I'm not going to kind of sit here and say, guys, you need to all spend half an hour on OHI. It's not realistic. You probably have, I mean, I've asked quite a few dentists and hygienists, and the time varies from like 3 seconds, which is probably brush your teeth, to like 5 minutes, which is a bit more comprehensive, but you probably don't have longer than that. So orientate your patients, show them where the gum line is, show them where they're trying to actually clean. Use radiographs. You know, if you had this radiograph here, show them these little bumpy bits here. That's the bacteria underneath your gums. That's what we're trying to clean. If we're going to use floss, it's going to go straight down and straight up. What we need to use here are nice fat interdental brushes. They're really going to scrub the sides of your teeth. And they'll be like, well, that's going to create gaps between my teeth. And say, well, the gap's already there, you see. You can see there's no gum there. There's no bone there. What we're trying to do is tighten up your gums. So yes, you will see a gap opening up, but that's good. It means your gums are tightening to health. That's kind of the way to orientate them and explain it. If you can disclose, obviously, again, you may be limited with time with this. You can use some like disclosing sponges or things like that to maybe just disclose a certain area if that helps. But objective plaque scores are really important. Even if you haven't disclosed, try and come up with an approximate like 50% plaque, approximately more than 80% plaque. Some sort of number is better than just saying OH, good, fair, poor, because that's not objective. Always demonstrate, always. Then this one, by the way, if you haven't got this Oral B test drive, try and get a hold of that, because you can actually demonstrate an electric toothbrush in the mouth. And I think models don't work very well. That feel component is so important for perio patients. Always demonstrate, always tell them about interdental brushes, show them in the mouth, single tufted brushes. Obviously, power brushes are way more effective than your manual toothbrush. You need to angle it along the gum line. I know this is sponsored by Oral B, but genuinely the Oral B, I think for gum disease patients, because it's got a round head, seems to work really well. I've made particular videos which are on our practice website and YouTube that they can then watch as well. So yeah, do everything you can to make it easy for them. Also, what I call GPS, which is an evidence-based way of changing behavior. So it's all good and well showing them and telling them how important it is, disclosing them. But if you don't give them some goals to finish off with, they won't actually change their behavior. It'll be the same thing again in a 3 months' time. So GPS, goal setting, planning, self-monitoring. Goal setting is saying, right, let's try and get your plaque score down from 80% to 40%. How we're going to do that, right, is by focusing on your brushing. That's all I want to focus on. That's all. Just focus on your brushing. Oh, by the way, I'm going to give you these disclosing tablets. I want you to go home, do your normal regime, then chew up this little tablet. Sorry, I haven't had time to use it today, but when you're at home, You chew it up, spread it around with your tongue, you'll notice the purpley pinky bits. Anywhere that's purpley or pinky, go back, clean those areas. And then you should notice the purpley pinky bits get less and less, and that means you're doing a good job. And that's that self-monitoring thing is so important. It's a bit like if you're trying to lose weight. If you don't look any different and you can't weigh yourself, you're probably going to lose motivation, right? That self-monitoring with OHI is super important. And obviously keep it simple, reinforce it every single time. And finally, reinforce their responsibility. It's 80% about what you do at home and 20% about what I do. That's why I'm spending so much time on this. In terms of what's to come, it's super exciting. And again, I know sponsored by Oral-B, but this is their new brush that's coming out. So it's going to make, and the one thing I like about it the most is the fact that it gives them positive reinforcement. So I know you've already seen the light that goes red. Obviously that means they're brushing too hard. But the great thing about this one is that it also goes green. So I think it's because we're always telling our patients off, this is really nice because it means, yeah, you're doing a good job. So that's probably my favorite feature of the new brush. There's lots of other things to do with it, but keep an eye out for that as well. Okay, moving swiftly on to, guys, we'll probably be done around, I would say, 20 past. I hope that's okay. But I just want to get through. I know it's a lot of information. I just wanted to give you everything I can about perio, what you need to know. So moving on swiftly to treatment. So treatment, we're talking about root surface debridement, right? So when do you do RSD? Obviously, you'll need a motivated patient. There's no point in doing it if the plaque score is like 90%. Any pockets that are 5 millimeter and above, and 4 millimeters with bleeding on probing. And there's no evidence that one technique is better than the other. So people always ask, do I have to do full mouth? Should I do quadrant by quadrant? Should I do half mouth? It doesn't matter. It usually comes down to logistics between you and your patient. Either technique is fine. And this is what you can achieve with non-surgical treatment. Look at that. I mean, this is amazing. And you might think, oh, that tooth needs to come out. But just with good non-surgical treatment here, we've got some bony infill. But more importantly, the pocket has reduced from a 9 millimeter to a 4 millimeter. So it's far more maintainable. What I'm saying here is give the tooth a chance. Unless it's like clearly hopeless, give it a go. Tell the patient, look, we're going to do a round of treatment. There are a few teeth here which we may need to take out. But let's give it a go and then take it from there. You'll be surprised what we can achieve with non-surgical treatment. You're probably using ultrasonics in practice, which is completely fine. If you do use hand scaling, it's great. And I usually use a blended approach. But if you're struggling for time, ultrasonics are great. One thing I would say for this is, remember the technique for ultrasonics is different to hand scaling. So for hand scaling, you go down to the pocket and essentially scrape up. With ultrasonics, you're starting coronally and you're working your way down using an erasing motion or pecking motion if there's any calculus. The key problem I find in practice is tips are worn down. And worn down tips are not great because even 2 millimeters of tooth wear is going to have 50% reduction in your efficiency. So get a wear guide, no matter what company you use, Cavitron, Piezo, whatever, get them to send you the wear guide and put the tip against. It's a great audit you can set up in practice. For the staff, anyone can do this, check it on a regular basis. If it gets to red, it means it's dead. And you need to replace it. It's worth investing in keeping up good instruments. Antibiotics, do we need them? In essence, firstly, local antibiotics are a no-no. They do not work. The companies, they work to a point, but not enough for you to justify them. There's great marketing out there for things like Perichip and so on, but is it really worth it? Wouldn't it be better for them to have just a little surgery and get it sorted, or non-surgical even with specialists? It may work just as well. So antibiotics local is no-no. Systemic for sure, but for very limited cases, and it's usually when the outcome is not as you predict, like plaque scores, what we used to call aggressive perio. Like plaque scores are excellent, young patient, quite severe disease. It can be beneficial here, but in general practice, rarely, essentially. Okay, and what about, whilst we're on OHI and so on, I just wanted to also briefly touch on treatment treating periodontitis, let's just briefly touch on treatment of periimplantitis. So essentially, if you're healthy, just reinforce OHI. If it's got perimucositis, i.e. it's bleeding, a bit of gentle debridement, especially if you can see some calculus, is fine. And again, reinforce oral hygiene. Do not use these plastic tips. They're a nightmare. And in fact, especially with periimplantitis, they break up and you get these like little plasticky bits and it's a nightmare. So just use normal stuff. You can use your normal ultrasonic. Obviously, if there's someone in your practice who's placing the implants, they might want to come up with, and you're not placing them, there might be a specific protocol you want to come up with in your practice. But essentially, perimucositis is all about just OHI and cleaning off any calculus. Perimplantitis, I would refer if it's out of your scope of practice. Perimplantitis is bad news. It's really difficult to treat. I wouldn't give the patient any major hope. I would just say, look, we'll just try and slow down the progression. I treat quite a lot of perimplantitis cases, mostly all surgery, resective surgery usually. And I just say to the patient that we're just trying to give the implant more life. At some point it will fail. Oh, my things seem to have cut out. Can everyone see my slides?
Yes.
Okay, I'm going to carry on. I don't want to present. I can't really see the slide anymore, so I will just. I should be on maintenance, I think. Okay, let's see if I can get this back on. Okay, I think I'm on supportive periodontal therapy, so I'll carry on. Okay, so SPT is super important and on a 3-monthly basis for patients with periodontal disease, that's your default. With perio patients, essentially your hygienist will come into a key role here. So always involve your hygienist if you're working with them and tailor the interval. So it might be 3 monthly initially, and then you may want to tailor it. So if they've got like diabetes and it's not very well controlled, then you may want to adjust it to 2 months. And if it is well controlled, you might want to change it to 4 months. Okay. Sorry, I can't see my slides. I'm just trying to work out where I am. Lisa, is there any way you can put me back on? Sorry, guys. Okay, Lisa, if you could, sort that out if possible. Okay, let me just try minimize, maximize. Just give me 1 second.
Button. Okay, and then click on present. There you go.
Okay, guys, are we back?
Okay, thank you, Lisa.
All good? Okay, so technology can be great, sometimes it can't. Anyway, let's go back. All right, so maintenance we spoke about. Sorry about that. No idea what happened, but anyway, so we're on maintenance now. So now moving on to.
Hello? No, we can't.
Hello?
Click mic only. No, we can't. That's not there. Is there a start button?
Hello?
Okay, we will do. Close the window. Yep. No, it doesn't let us do start, so click this.
Hello? Hello? Hello?
Can you hear now? Hello?
Hello? Anyone?
Okay.
Yeah, all good? Okay, I think you can hear me. So we'll carry on. We'll move on to referring now. So for some cases, obviously, you may not be able to treat it in practice. So you may then need to refer them. So let's have a look at when you might refer them. So with referring, there's one key kind of guidance to follow, which is the one that was released by the BSP. And essentially, there's three complexities. So there's three reasons why you might, three complexities, and it's complexity 3 that you want to refer out, essentially. So complexity 3 essentially involves any BP score of 4 plus an additional risk factor, and the BSP have got a whole criteria on their website, so it's worth reading that. The other criteria to think about is stage 4, grade C. And they're your severe susceptible individuals, essentially. So look out for those as well. In terms of breaking it down when you're referring, and the reason why it's so common in terms of litigation, because remember we said the two biggest reasons to litigate against is failure to diagnose and failure to refer. The reason why people get litigated against is you think they don't care, and then suddenly they lose a tooth and they're like, hold on a minute, why didn't you refer me to a specialist? Why didn't I? Now you're going to pay for my implant, da, 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 da. So it becomes this whole thing. So I would say minimize any delay, offer it to every single person and offer it at every single visit, even if it's just for treatment planning. The kind of cases to look out for: periodontitis, what we used to call aggressive. Patients you've done a few rounds of treatment on and it hasn't resolved. Residual deep pockets, sometimes associated with vertical defects. Gingival overgrowth as well. All of these types of things. So this is a case or generalized, what we used to call aggressive, deep pockets everywhere, severe bone loss everywhere. We did a pocket chart, deep pockets, severe bone loss. So we got generalized aggressive. This is when the classification hadn't changed. And what we did was a mixture of things. The local dentist did the extraction. I did some non-surgical with adjunctive antibiotics, did a little bit of surgery, and then she's good for maintenance. And you can see, yes, she's got a bit of recession, but it looks far better. And the probing depths are all 3 or 4 millimeters or less, which is the best thing. So two things here. Firstly, find a good periodontist, because often it's quite a team approach. The hygienist will do a little bit, GDP will do a little bit, specialists will do a little bit. So get to know your local specialist and build a good relationship with them. Secondly, even for these severe genetic cases, they work really well. So don't be, you don't want to scare the patient and say, oh, you're genetically determined and you've got really severe perio. You can say, yes, it is very severe and you are susceptible, but it doesn't mean we can't treat it. It doesn't mean we can't get on top of it. If we do need to do surgery, there's two types of surgery we do. We do resective gum surgery, which essentially you're cutting away pockets. Like this distal of the 7 here, you basically just do what we call a distal wedge. You cut out the bulk of the tissue. Sometimes you reshape the bone. Or if the anatomy is correct, i.e. you've got 2 or 3 bony walls and it's like a little container, you can actually fill up that area with a bone graft. So something like Emdogain, which we used here. And you can see in the radiograph how it looks 6 months later. And Emdogain is actually radiolucent. So this is actually bony infill. You can't really say if it's regen, but I mean, if you looked at that post-op radiograph, you'd be a lot happier with that 6 than you would previously. And the key thing is the pocket's gone down from a 9 to a 4. So that's 2 ways of treating pockets. The other one to look out for in terms of this periodontitis category is your overgrowth patients. So with overgrowth, we've already gone over this, you'd probably do a round of treatment. If it looked like that, you might need some surgery. And here we've just resected the bulk of the tissue. Your aim here is trying to make the gingival tissues more amenable to oral hygiene. And that's what you're doing with surgery. Your second category is recession. So for recession, this is becoming more and more common. In fact, I have quite a few patients presenting themselves saying, I don't like the way this looks. So I think this is going to become a popular treatment amongst patients, especially with more people doing things like Invisalign and all those types of things. And there's a few examples here. This is one: lower incisor, post-ortho, localized recession defect. The problem here, right, is not the amount of recession. It's the quality of the gum tissue. So I'm not that worried about how much recession is. I'm worried about how thin the gum is, how unattached it is, because firstly, this is going to really hurt the patient when they brush. And because it hurts, the recession is going to progress even further. And then because it's so thin, again, when they get more plaque there, it's going to progress even further. So this needs treatment. And it's so easy to use something called a free gingival graft. very, very predictable. Take a little piece from the palate, stitch it on, nice, thick, tough gum, which means they can clean the area well. You've, even if they do get a bit of plaque there, you've protected that tooth. It's not going to recede any further. And the key thing here is, yeah, it doesn't look glamorous, but hopefully no one's going to pull your lower lip down and have a look at that. You can do other aesthetic surgery there if you want to, but it's slightly less predictable. Here's another few examples. If it is in the aesthetic zone, of course, there are surgeries we can do, coronally advanced flaps, things that we can do to really make a big difference to the outcome of the final aesthetics of the smile. Here I worked with my referring dentist who did a composites up to the CUJ, and then we did an advanced flap to correct the recession. And here is a more complex case. So, I mean, I love this kind of surgery. It's so fun. So look out for these cases. I mean, before my specialist training, I didn't even know we could do this. So it's just knowing about what's available. And then finally, you've got your crown lengthening. So restorative or aesthetic crown lengthening, that again might need referring, like a simple restorative case here, just part of the tooth which was subgingival that we needed to lengthen. Or, you know, more aesthetic cases. After this, you might want to do your Invisalign, whitening, composites, all those kind of things. But it's a good start. Or even just a single tooth. And this is a more complex case that one of my referring dentists sent me. I did the gum lengthening and then the what they call gum lift now patients. And the dentist did the composite veneers after. She looks so much better. She was an actress basically, and the in terms of critique, they were saying that her smile wasn't very nice, which I think is really mean. But she was very conscious about it, and she got a great result. In terms of referring, there are various options. I work in the hospital as well as my private practice, so I've got kind of seen both sides of the world. It's very difficult in terms of hospital referrals. I know that sometimes private is the only option, but be aware, some of you will have in-house periodontists. You're winning if that's the case. If you do, tiny little plug here, need a London periodontist, if you've got patients who work or travel into town, if you want some more information, just let me know. Just drop me an email. I'm based in town. And in terms of what to say to patients, tell them about the severity, you know, be black and white with perio patients. What I find is sometimes they don't take on referral if you're kind of a bit wishy-washy and grey about it, like, oh, we can see how it goes in 3 months, and then they end up losing a tooth. You have severe perio, you're going to lose your teeth. It may impact on your general health. Let's get you to see a specialist. They'll get you healthy and then get back to me so I can maintain you. Keep it really black and white. Then ask lots of questions. Expense is a key one, and most practices will offer on interest-free finance. So the way to explain expense is, firstly, you can split the payment. So, you know, most treatment plans for us will be about £70, £80 a month. So you can spread it a year and a half. What's the cost of not treating this, right? If you lose that one molar, how much is an implant? 2-3 grand? Like, my treatment plan will never go over that for the whole mouth. So put it into perspective for them. How much is your cost per tooth? We're like, again, 60, 70 pounds. So perio is really affordable, especially when compared to the specialties. And final bit is, in terms of reducing your medical legal risk, we've gone through quite a lot today, which will do that already. And again, I can send you this presentation as well, but these are just some phrases that you might just want to screenshot and use to update your templates. And of course, you need to say it to the patient as well, but having good notes, good quality notes, can really save you in certain conditions. Perio, as I said, is the biggest one. So it's just important to be aware of that. So I should have mentioned this at the start, but there is still a chance to say this. But Dental Update have kindly put forward a competition for everyone today on watching this webinar. And if you take a screenshot of this or any part of the presentation and put it on Instagram and tag Dental Update Mag and RW Perio and share it on Instagram, then they're going to pick someone to win a whole year's worth of subscription for Dental Update, which I think is a fantastic prize. So guys, still do that. I've got a couple more slides left. I'm going to go through a few questions and then finish up in the next 5 to 6 minutes. So a couple of questions. Thank you so much for all the kind comments. I hope I've kept you engaged. Sorry about the technical issues. These things happen, I guess. How do water flossers compare to flossing? Great question. So the way I explain this to my patients is water pick, air floss, all of that kind of stuff. It's a bit like, right, if you had a dirty dish and you just rinsed it, it's a bit like that. What you really need to do is scrub it. So if you really want to use it, that's fine, but it's not a replacement option. We need that interdental brush to scrub it off. TP Easy Picks are actually quite good for patients, especially they don't have they're initially getting used to the use of interdentals, and they've got tight interproximal spaces. I think they're great, but ideally you want to use the brush. I don't have a preference to in terms of magnetostrictive versus piezo. In terms of rotary or sonic, I think that's what you mean. So yeah, either is fine. How long does it take to get a 9mm pocket down to 4mm? So deep pockets, you're expecting 2mm of improvement. So like anything 7 and above, 2mm, and that takes 2 months. And anything with a moderate pocket, you're expecting about 1mm improvement, and then plus a bit of recession as well. So it varies. It also depends on the healing of the patient, things like diabetes and things like that. Are ultrasonics safe for cardiac patients with pacemakers? It depends. With the Cavitron magnetostrictive, I wouldn't use it until you have clearance from the cardiologist. It's just not worth the risk. More than likely, the latest ones are fine, but I just wouldn't take that risk. So if you really want to, just get clearance for it. Okay. Okay, so just to finish off, I will be done now in 2 minutes. If you need, I'm sure everyone's keeping themselves occupied with webinars, but I've set up a free email series. And if you want to get useful, I've got good feedback so far. So if you want to get useful information to your inbox about perio on a pretty much daily basis, I've tried to make it as useful as possible. Please sign up to the perio series emails. It's completely free. That link is there. So bit.ly/perio school email. It'll be good to have some of you on that. And if you have questions, you can always email me back, and we'll have like a learning essentially session. It'll be fun. Reading, you probably have lots of webinars to watch, but if you prefer to give your eyes a rest in terms of the screen, the two biggest, hopefully the most useful papers for perio as a summary are two of the ones that I did for the BDJ, 20 common questions, FAQs. You've got all your evidence base there for the 20 most important questions, most common questions. So if you can't find the link, let me know. I can send it to you. When we are back on track, if you want to, I love perio, and I wish more people loved it. I know it's really important, but it's so fun as well. And if you want to learn more about things like crown lengthening, especially GDPs out there, you can definitely do some simple crown lengthening practice. There's no reason why you can't be providing this yourself. So I do a hands-on course. It's back on in October. If you're interested, again, just go to the website or just email me. I can tell you more. Similarly, I run something for hygienists as well. Again, hands-on. We have a mentoring program as well attached to it, which we come onto the clinic essentially, and we see patients together. Again, you can have a look online. If you have any questions, just let me know. Thank you so much for your time. I hope you found it useful. Sorry, I've gone over a little bit. If you have any other questions, let me know. I've got a dental blog, which is rinawadia.com, if you want extra reading. And my practice is RW Perio. So if you are kind enough to follow me on Instagram and you want to look at lots of gum pictures, pink stuff, have a look at it. But thank you so much for your time. That's my email address. You are more than welcome to email me at any time. I'd be happy to send you my presentation if you just prefer the slides. If you have any questions that I haven't been able to answer within the time available, then I'm happy to reply via email as well. I hope you enjoy the rest of your evening. Once again, stay safe, and yeah, enjoy the rest of the webinar series. Thank you.